Welcome, everyone, to today's webinar. I am Brian Zimmerman with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. We will also have a series of audience polling questions during today's webinar. When we reach each poll slide, the poll question will pop up automatically on your screen. Our speakers will give a few seconds for you to select an answer from the options on your screen and click Submit. Thank you in advance for your participation. This session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation and a PDF of the slides to the email you used to register. Our presenter for today's program are John Giuliani, Vice President, Operations, Healthcare Financial Resources, and Daniel Lau, Director of Operations, Healthcare Financial Resources. John Giuliani has over 10 years of business process improvement and healthcare experience and currently oversees the operations of HFRI. Before joining HFRI, John oversaw and managed a business analyst unit within Philips Healthcare. Daniel Lau started his career with HFRI as a collections supervisor and has had multiple roles with HFRI, including quality assurance manager and senior client program manager. Daniel has over 12 years of hospital revenue cycle experience. At this time, I am pleased to turn the floor over to John to begin today's presentation.
Hello, everyone. Thank you for taking time out of your busy days to discuss with what I believe are very important topics. As previously stated, my name is John Giuliani. I joined the team here at HFRI in Chicago a little over 4 years ago now. Previously, I was with Philips Healthcare, but my background was more in the data analytic and the operational process flow improvement side. So one of the things that excited me about this industry was the vast amount of data that was available and all the opportunities that were out there because of it. Now, that being said, while there's an incredible amount of data out there, it can be quite difficult not only obtaining it, but more importantly, making sense of it. Thus creating what is referred to as dark data, which basically is unstructured and untapped data that has been analyzed or processed in an unmeaningful way. For some of you, that may be a reference to the EDI data feeds between you and your payers. Even if you feel you're getting the basic information through these files, you'd be amazed on how much meaningful and actionable insights are being missed. And later in the presentation, we'll actually cover some of these items. And why is capturing and analyzing your data becoming even more vital to the health of your organization? Well, because the recent trends with reimbursement are not favoring hospitals. Even though there's been a focus across the industry to lower occurrences of denied or delayed payments, the average 350-bed hospital saw denial write-offs jump 79% from 3.9 to 7 million between 2011 and 2017, according to a Becker's Hospital CFO report. In 2016 alone, $270 billion of U.S. hospital claims was initially denied. The administrative costs of reworking these claims are now approaching $9 billion. So even with this incredible investment, only about 35% of these rejections are ever reworked and submitted for reimbursement. With the average hospital operating margin being less than 3%, having over 65% of denials never getting corrected and resubmitted is a tough pill for many CFOs to swallow. Especially when you take into account that it's been determined that while 66% of these denials are recoverable, well over 90% of the claim denials are actually preventable, according to the advisory report. So what do these trends tell me? That too many hospitals are continuing to use an outdated traditional approach to handling their claim issues by simply throwing bodies and manual labor at a growing problem that is filled with increasing complexities. This is resulting in hospitals routinely leaving large amounts of money on the table. The money is there, and you're entitled to it, so you just need to go and get it. Now, it's easy for me to say something like that, but it's vital that this process is done efficiently. That's where the importance of utilizing the advancements in technology comes into play. Robotic process automation, known as RPA, and intelligent automation are emerging as key elements needed to help hospitals reverse these latest trends. In fact, they're becoming table stakes for hospitals even when considering vendor partnerships within their organization, and rightfully so. RPA is software that can be programmed to do tasks across several applications that human workers are assigned to handle. The bots, as they are often called, can handle repetitive tasks faster and more accurately than human workers, thus freeing them up to handle tasks that require more emotional intelligence, such as interaction with patients. Intelligent automation is the next level of efficiency when it comes to automation as a whole. As pointed out in our slide, it takes multiple data sets and performs deep data analysis to identify and handle the issues with the highest occurrences. Meaning the bots are capable of automating entire processes or workflows while learning and adapting as they go. I obviously don't have to emphasize to this group the importance of that technology in an industry where what you knew was resolved today has completely changed and needs updated tomorrow. Now, when you take the productivity advantages of RPA and combine them with the machine learning and quality advantage of intelligent automation, you find yourself equipped with tools that not only will enable you to go after the 65% of denials currently not getting worked, but more importantly, put you in a position to present or prevent 90% of your total denials in the first place. This technology enables several automation opportunities as shown by this slide. The bots will enable you to not only classify your issues by root causes, but also gain insights from an analytical perspective, which will provide the roadmap on where you should focus your resources. The next few automated opportunities can have a significant impact on your staff's overall productivity, even if completed separately. For example, in regards to the automated notation, our studies have shown that one of the key differences between high performers and low performers is the amount of time it takes them to complete their notation. We all know that with how complex these issues can get, it's critical for reps to articulate their work and current statuses coherently and accurately. The high performers were able to summarize this information in 2 minutes or less, where low performers had an over 300% increase in the amount of time it took them to express what they were doing. And more often than not, it was not clear on what they were trying to say. While the impact of an automated note will increase your low performers' productivity, keep in mind you're increasing the productivity of even your best employees. When you factor in the 1 or 2 minute time savings on your top performers across thousands and tens of thousands of accounts, we're talking about some significant cost savings over time. And this is just on account notation. It's accomplished by applying the action code used by the user, or bot if that action was automated, and then having the bots auto-populate a note template of all relevant information on what was completed. Another key opportunity is with automated appeals. Reviewing the EDI data, the bots can determine if an appeal is even necessary, then generate the proper documents for submission. By giving the bot access to your contract management software or maintaining a payer matrix, intelligent automation can cross-reference this information alongside the denial log to ensure that appeals are going to the correct entities without any human involvement, thus allowing your process to automatically identify where underpayments occurred and auto-appealing instantly. This will allow you to spend your time more on where it needs to be, with the management of your payer contracts, and less on your staff's ability to get those appeals out before timely filing deadlines hit. Automation opportunities don't end with notation and appeals. You can apply it with your adjustments and your NRP processes in order to eliminate the risk of incorrectly applied adjustments or money sitting in the wrong bucket. The bots can also be assigned to ID missing payments or misapplied cash in your system to ensure it's assigned to the appropriate account. All these opportunities will lead to an increase in cash flow, a reduction in write-offs, and a decrease in bad debt reserves caused by aging accounts. That, on top of improved efficiency amongst your staff, leading to less turnover, will lower your costs while increasing your revenue, which will obviously have a positive impact on your bottom line. While I could certainly spend an entire webinar on each one of these opportunities, today we'll be focusing more on the automated denial classification and data analytics. So before I hand things off to Dan, I do have a quick polling question to ask the group. All right, so our first question is, how many of you are currently incorporating automated notation or appeals in your process? We'll give everyone some time to get your answers in. So Dan, one quick question while we're waiting on everybody. In terms of the multiple, effects we have and opportunities with automation, what about notation and appeals do you think drives the overall importance of it?
Well, for us, I think the biggest importance is ensuring that the first follow-up action by our staff is as accurate as possible. And by using a process to identify that we'll be discussing in a few minutes in terms of denial crosswalking, we can determine what the issue is at the first review on the account, and then we can instruct the staff exactly how to follow up from that point forward.
Makes sense. All right. As we're totaling up the results, should see that soon. So one thing we're seeing is the majority of you are actually not currently incorporating, and that's to be expected. Probably makes sense why we had a decent turnout for today's discussion. As pointed out earlier, with the recent issues hospitals are facing, it's obvious this process is time-consuming and frequently involves multiple conversations with the insurance representatives. As payer contracts have become more complex and the volume of denials has increased, the ability of staff to keep pace has diminished, meaning it's more important than ever before that all hospitals and organizations take advantage of automation, and in all areas. And it's very well understood that people may not have thought of notation as being the first thing to automate, but when you can see the significant impact it can have on your overall productivity, it's items like this that we need to be looking into. And Dan will be diving into this just a second, but it's really in that focus of being data-driven that needs to lead where we go with this.
Okay. Well, thank you, John. As John mentioned, my name is Daniel Lau. I'm currently the Director of Operations, so thank you again for everyone joining today. My main focus has been really working with the Trend Analytics Department as well as IT to find areas to improve processes, whether that's through our own internal system or through the hospitals that we work with. So one starting point before you can verify where the opportunities are is to create a denial crosswalk. So determining a denial crosswalk, in order to classify denials or start advanced denial analytics, the first step would be to create this denial crosswalk. The way you would do that is you could parse data and write rules that allows you to choose a winning denial reason. There's a lot of denials that can be applied on one account, and figuring out the rule sets to craft the actual biggest problem on the account is a huge step. Utilizing RPA scrape data from EMR or other software systems or websites will allow you to take information that you didn't have available on an 835 response for and help craft a follow-up experience for the next rep. Mapping CARC and RARC codes, which I'll go through a little bit further later on in this presentation, are basically the remittance descriptions on EOBs. But when you map those together, along with viewing examples, it allows you to see what the denial issue really is describing for accurate mapping. And based on what your mapping shows, you can create an overall classification of groups. And so what we're about to go into is how we classify our denial categories, and we can walk through how that process has worked for us. So in terms of automating denial classification, by analyzing and classifying billions of dollars of claims, this is what we show as our classification breakout from a very high level. So I'm going to review each denial classification with you all right now, and examples of what can be identified when you actually dive into these categories in terms of what can be considered process improvement or kind of things you can identify through trend analytics. We'll also be reviewing a no authorization root cause analysis for an in-depth review of what you can do once you identify the subset of information and what you can provide in terms of analytics to yourself or your clients. So the first category is utilization, and these are classified by billions of dollars of analysis on our end. Utilization has been showing at 25%, and what that's categorized is more of the clinical rejections. So you're going to be running across your no authorizations, your medical necessity, experimental, and level and length of stay issues. And we'll be diving into specifically no auth in a moment. In terms of coverage at 21%, these are your services that are rejecting for COB, no active insurance, or non-covered benefits. While reviewing these denials, it's consistently identified that there's opportunities for better following electronic eligibility responses prior to billing in terms of things being e-rejected and pushed through, or verifying the order of insurances for Medicaid or Medicare patients. In terms of contractual, over at 17%, these are services where the expected amount in the contract management software is not being met by the insurance company. An example of something along these lines is while we review these potential underpayments, we consistently find that a lot of the times it's due to the fact that the plan codes are loaded incorrectly on the front end, which causes the expected reimbursement to look inflated. And understanding how we can improve processes on that front end will more accurately reflect what the CFO is looking at in terms of potential cash coming in. Coding and billing at 15%. These are the services rejecting for not following billing or coding guidelines. One of the biggest areas of opportunity is modifier usage or application, and this does drive a significant portion of these rejections. Submission and resubmission is at 15%, and these are services where the account requires a bill to the secondary or a resubmission due to a registration error. So one big thing that we had identified recently is ensuring the primary EOB attaches during a secondary billing is an interesting reason as to why claims can get delayed in terms of their processing, and they're always pending for that primary explanation of benefits. So ensuring that a document number of the primary EOB is listed on the claim will ensure your billing system is talking to the clearinghouse and making sure that EOB gets attached in your secondary billing. Cash posting is on the smaller end from what we're seeing. These are services where the resolution is delayed due to an offset or a refund or have an unapplied cash issue in the EMR system. So an area where you can use the EDI files is you can verify that they have a claim status code of 22 for takeback, and you can specialize teams for follow-up to ensure that those offsets or other types of issues are focused on for immediate resolution. And the final piece at 3% is process delays. So these are going to be your problematic payers where processing, appeals, or funding takes longer than normal to get your claim overturned. So ensuring medical records, if possible, can be submitted with the bill to the payers that require them, like the VA or workers' comp, can ensure a quicker resolution in terms of getting these claims overturned. By classifying your denials into categories, they don't have to be these exact ones. These are the ones that work for us. But the benefits of this is that you can, one, identify the issue immediately and implement denial teams that can focus specifically on those issues, and they become experts in that issue, which is going to improve the fact that your initial follow-up is accurate. It's going to also increase your cash. It's going to ensure that your aging doesn't get out of whack, that your automation and trend identification is easier. And what you can do through this is you can create rules based on the identified information that your staff or your trend analytic departments can bring to you. And something really kind of interesting that has kind of popped up recently is that by mapping your CARC and RARC codes, you can create an at-risk report. So you can verify whether the timely filing for your issue is related to initial billing, corrected claim submission, or appeal. And then you could link in a timely filing interface so you could verify that your claims have a certain time frame from that CARC and RARC combination until the claim is officially dead and no more cash is available, or if you could verify which claims have the potential to bring you in your cash. So diving into the next piece, I will pass this off to John to go over the next polling question.
Yeah, so we do have another polling question, as Dan pointed out. So what is the primary criteria that you are using to categorize and assign claims within your organization? And Dan, while we're giving them time to answer, I mean, do you have any thoughts on what you would personally go with?
So I think, as everyone could tell from the previous slide, my main focus is really denial-based, but you can't just focus on one main thing. Denials are obviously the top focus that I would like to look into, but each payer has set ways that they use CARC and RARC codes or their explanation codes. So I would craft my denial reasons based on the payer specific, and then always work largest to smallest balances to ensure that we collect as much money as possible.
Makes sense. All right, data is gathering. We appear to have almost a virtual split between payer and denial reason, which again isn't surprising to us. And one of the main things we believe is, you know, yeah, maybe we start with denial issues, but you can dive down to very specific reasons and break it out by payer, balance, and get in other areas as well.
Okay. Well, thank you all for your feedback. We're going to be diving into the utilization assessment of no authorization. So some of the information that you can gather from doing data analytics and mapping CARC and RARC codes is you can start to see exactly what's happening in your inventory and then allow for deep dives to happen from that set point. So one opportunity is to show you guys an example of mapping. But before we get into that, just to bring everyone up to speed, if you're not familiar with CARC and RARC codes, a CARC is a claim adjustment reason code that details information on a remittance, an explanation of benefits regarding how a claim processed. Your RARC code is going to help you describe exactly what's happening within that CARC code. So this chart here is kind of an example of a mapping classification that we have. So if you're trying to verify what services are denying for no authorization under CARC code, those would be the 197 and the 15. And looking into the RARC codes, the M62 or the N175 is going to be driving the exact reason behind it. So for instance, if I was trying to see why my 197s were attaching with an M62, I would know it's missing or incomplete or invalid treatment or authorization code. Depending on which classification under utilization you're really looking into, it can be the deciding factor to help you determine what's actually happening on your account. So with that, we're going to be diving into an authorization review. So in front of you is an example of a deep dive into a 197 review. And 197 stands for pre-certification or authorization notification is absent. So the first piece is to figure out a root cause establishment. So you're going to be looking at, was an authorization obtained? And from the analysis that was provided on this subset of accounts, 64% of the time it was initiated and incomplete or incorrect. And 36% of the time there was no authorization obtained whatsoever. In terms of which carriers it affected, United Healthcare was the #1 at 30%, followed by Blue Cross and Aetna, and then Aetna Medicare finally at 10%. And the information that you're really wanting to gauge in terms of responding to internally or to a client is what is the details on why that auth was initiated, but why was it incomplete or incorrect? And the #1 reason seen in this review was that it was not medically necessary 23% of the time. The interesting pieces come to light, though, once you start looking at the smaller breakouts, which is 17% it was authorized for the wrong date of service. So there's some opportunities in terms of training and front end there. The incorrect CPT codes were authorized 15% of the time. 10% of the time, the peer-to-peer pending was incomplete. The peer-to-peer was denied 8%. The wrong insurance was authorized 5%. Only one service was authorized when there was multiple that required it. Incorrect patient was authorized at 5%. And you can see the smaller ones at 3%. There was an incorrect facility. A retro request was denied. An auth was withdrawn, or the wrong auth number was on the bill, which is the reason why it actually didn't complete. So there's a lot of opportunities from analyzing something in depth like that, and I think a lot of people really like to see what's truly driving the problem so you can dive into where you can improve your processes. In terms of the accounts that had no authorization obtained, the system was coming back with an NPR, which is no pre-cert required, when in fact it actually did require a pre-cert. There was 23% that had no documentation at all, as if that account was skipped, or those accounts were skipped, and 15% where there was a coverage change in between everything, which is the reason why the service was not authorized. They had the wrong insurance listed. So something to take away from this 197 review is that the majority of all these services are related to radiology. So if you're working with a specific department, ensure that when you're running across UHC, Blue Cross, Aetna, and Aetna Medicare, that you have rules in place to understand which services do require auths and which ones do not. The next thing that we're going to look into is just because there's one code that means that it's denying for no auth doesn't mean that there's other codes that don't mean the same thing. So CAS 15 or CARC 15 is also denying for no authorization. It's missing or invalid, but it has a completely subset of different denial information. The first review that we would dive into is that CAS 15 was only affecting the Medicaid services. And the specific reasons that they weren't paying was, the number one thing is that no auth was being initiated whatsoever. And 4%, all the services were not authorized, only partially. 2%, it was an invalid auth on the actual UB. And then 2%, we had an auth mismatch. One interesting piece that was identified is that they were Medicaid therapy accounts, and regardless of the plan, whether it was an adult or a children's medical service, they required an authorization. So some interesting information is which specific CPT codes were being rejected in this instance for requiring an auth, and so we had listed these on this table to allow for a process improvement approach in terms of when to get an authorization and when to let the front-end teams know exactly when that was required. And the service areas that were affected overall, the highest, were going to be your physical therapy at 40%, your occupational at 34%, your speech at 22%, and your physical and occupational at 4%. Something also very interesting is that there was an influx of children medical service claims. And because there was an influx of that, there's an opportunity on the front end to say, when we're seeing this and it's for a therapy-related service, we're going to be requiring an authorization. And obviously the adults as well required the exact same thing. So what are the pillars of process improvement? And in my mind, and I think overall, is that you have to have a back-end analysis of really what's happening with the front-end teams. So is there steps in place to following carrier requirements for service, facility, and patient criteria? Have you found and validated the carrier trends overall? And have you found and validated the service areas as well? And once you have that information, that allows you to do the next step, which is your IT rule creation. If there's any big wins in terms of how you can automate a step, you have the data behind it to make that happen. So you're going to have to write rule-based application to reduce those manual touches. And when you're writing a rule, the best focus that you can have is that those accounts either can be auto-adjusted or NRP to the next responsible party so that these accounts can be removed from your AR. If they can't be and they require actual follow-up from a staff member, you can create rules for that known payer issue. So if I know, for instance, that service is truly a covered benefit, I can then say I would need to challenge the payer and potentially create an appeal through that, or have my staff follow up to try to overturn that problem. And the most important piece is the front-end staff and training calibration and ensuring that there are desk procedures ready for education to these staff members. They are the front line, and without those being focused on, those errors will continue to occur. And so keeping those training materials current to carrier guidelines is very pivotal, and working with your clearinghouse to ensure data is accurate and populated in the correct fields is also very necessary.
All right, so now getting into one of our final polling questions, we'd be interested in seeing what do you all use as your leading indicator of cash flow issues? Now, while you guys are answering that, you know, obviously all these issues are important, but, you know, we are interested in, you know, kind of getting the mindset of the group on what you feel, you know, is the first indicator through all this. You know, with working with our clients, we find it sometimes can be depending on what position you're talking to. You know, where the management side, you know, maybe thinking that denial increase, that's the first thing they're going to have to answer for. Well, if you talk to some CFOs, they tell you it's the bad debt reserves you got to keep an eye on. So it's all interesting aspects. All right, so the results are still totaling up. We see, and to no surprise, it's the denial increase that the majority of you, basically about 50%, feel. And another interesting thing is the increase in bad debt reserve had the lowest amount. So maybe there's not a whole lot of CFOs on the webinar today.
Okay. Well, to summarize the overall presentation, having access to data is always going to drive your process improvement opportunities and is the most important piece to figuring out where you can apply any type of automation opportunity. Utilization of RPA technology along with system accesses is going to open up avenues for intelligent automation for data that you normally would not have access to. Back-end data analytics are key to identifying process opportunities through IT assistance, as well as training calibration. And finally, classification of CARC and RARC codes empowers specialized staffing, as well as timely resolution. So in terms of intelligent automation, driving AR process improvement through intelligent automation will increase cash and reduce aging, AR days, and improve staff efficiency overall.
All right, well, I would like to thank everyone who showed up today and participated. Now, we are going to have a QA session, and Dan and I, we feel these topics are critical for organizations that are looking to get ahead of the curve when it comes to tackling their ever-growing complexities of revenue cycle. But today's webinar was sponsored by HFRI, so before we get into those Q&A, I would like to tell you just a little bit about who we are. And HFRI is a leading insurance AR recovery and resolution outsourced service provider. We're located right outside Chicago in Elgin, Illinois. We're a national firm with a client base across the nation, with a strong presence in the Midwest, the West Coast, as well as up and down the East Coast. Now, we're capturing data from all these regions, and this has truly given us a competitive advantage to learn the leading issues for each area and make sure our clients are aware of what's developing in real time. Our focus the past several years has to bring these new technologies and business process engineering to the critical area of AR follow-up. HFRI has been in business for well over 20 years now, and we've applied the knowledge base and established process flows that were derived over the years with RPA and our intelligent automation. It had virtually an incredible impact on our internal organization, and obviously not just internally, but the true value we bring to our clients. This allows us to process all claims regardless of size with our intelligent automation and breakthrough workflow procedures. And this is designed to let us deliver scalability, speed, accurate resolution of every claim. And with HFRI is your primary AR recovery partner. You can experience collection rates on problematic issues of over 75%, a level twice that is typically achieved by the traditional AR follow-up firms. But just as important, our clients on average have experienced a 25% improvement in their resolution time. In addition to performing the account follow-up services, HFRI will provide at no additional cost an in-depth root cause analysis. And Dan was kind enough to give you guys a snapshot of some of these things. And that's how these presentations are designed, you know, diving into the root cause of the root cause and, you know, seeing in real time where these issues are coming from and how we can solve them. You know, and through this process, our clients on average have experienced, you know, accelerated cash flow as well as a 30% reduction in denials, you know, from even occurring in the first place. And then lastly, even if you already have a great relationship with an AR recovery firm, you still may benefit from our final effort insurance recovery service. And this is basically where we'll work super age claims after your CBO staff, you know, primary vendor, all prior to you writing off the balances. You know, our automation and data analytics gives us the advantage of truly vetting each account in order to squeeze out every ounce of cash that's owed before it's written off, which can have, you know, a positive impact, not only reducing your aging, but also reducing some of your bad debt reserves. In fact, for one of our clients who happens to be a major academic hospital, we recovered over $50 million prior to them giving up on the accounts. And with the average operating margin being just 2.7%, I mean, hospitals can't really afford not to follow up on every dollar. You know, so some of this is just, you can see reasons why it's important to dive into the automation and how, you know, whether you're doing it internally, you're vetting your vendors, you know, it's critical now to ensure that automation is being applied, or else the problem will just continue to grow. Now, if you have any interest in learning more about HFRI and how we can benefit your organization, please feel free to contact myself or visit hfri.net. All right, so with that being said, why don't we dive into some of the questions that we've seen pop up. Our first question, which is very reasonable, what are some of the examples of auto notation? Dan, you wanna handle this one?
Sure, of course. So auto notation can be crafted based on, you know, multiple rule sets or easy fill-in details. So one big focus of auto notation for us is going to be a follow-up instruction. So we can take the 835 information that comes across through the EDI files, and we can apply what's actually driving the issue of the account at this moment. And from that point, if we don't have specific EDI detail as well, we can actually have manual staff who are very efficient review the accounts as well. And then from that point, we can figure out how we can fill in any templates or any rule sets from that point.
Yep, for sure. All right, let's get into another one. All right, another reasonable question. How are you appealing denials?
Well, in terms of appealing denials, I'll use managed care accounts as an example. So we can identify small balance clinical rejections and create auto appeals to attempt to determine medical necessity and challenge what the payer has come across with. So we can pull the records and attach them to an automatic appeal with a template for these smaller balance clinical rejections. Another opportunity would be scraping the contract management expectation from client EMR systems or getting that in a flat file and being able to challenge line by line or from a claim level of how the insurance carriers are actually expecting and seeing which claims are truly underpaid.
And then Dan, personally, in reviewing the automated appealing, I mean, are you finding that it's much more efficient and accurate than the manual appeals, or is it still a plug-and-play process? So
it's going to be, I think, more efficient. I mean, it depends on your overall breakout and information that you have available to you, but when you're looking at the contract management software and you're looking at the 835 information, it's just a simple subtraction or verification in terms of how they paid. So you would see that they paid a set amount, the contract is expecting this amount. As long as the plan codes are loaded correctly, you have your appeal and it's 100% accurate.
Okay, going through the questions again. Here's one I really like. Why shouldn't hospitals just go and get RPA and intelligent automation themselves and not deal with vendors like yourselves? Well, that's a great question. And quite frankly, a question I get asked a lot while meeting with potential clients. My answer to that's simple. You should do both, yet have realistic expectations. Meaning, while there's certainly some great software out there, there's no special software that's already programmed to all your processes. I mean, Dan, would you agree with that statement? So, I mean, I'd say whether you're just beginning your automation journey or even if you're leading the charge, you should first determine what the most effective use of your resources are, and then find vendors that are best equipped to handle the issues you're currently not focusing on. You know, and like I mentioned before with our final effort, you know, aged inventory is a great start. So, and if, just for those, if you are getting started internally on this, you know, it's important to remember to use the data as your starting point. And I mentioned that earlier. You know, this will help your team narrow your focus and establish your priorities. It's very easy to lose sight of the forest for the trees in this process. You know, there's a lot of potential rat holes out there, and to be frank, I mean, that's why a lot of organizations fail, because they don't know where to apply their focus. So always go with data-driven decisions and not assumed assumptions, even if that person's been doing this for 20 or 30 years. While they'll have a great insight and they'll be a very valuable resource for you in terms to make progress in your automation, trust the data and make sure you're at least referencing it before you get started out. And as we laid out previously, it's imperative to have a systematic approach to applying automation. You know, you need to utilize your data to assess your front-end teams, find those biggest pain points. You got to dedicate your revenue cycle subject efforts, whether it's a manager or you know, the frontline staff. You know, one of the things that we do here is we'll make sure we're communicating with our staff, the ones that are seeing these accounts as they're coming in the door, because they'll be the ones to tell you, you know, here's what they're seeing. It's one thing to, you know, have a thesis and a plan, but once you get in the real world, you have to be able to adjust and, you know, reallocate it appropriately. And you need to work closely with your IT department. You know, you gotta be able to create and establish role engines for both your bots, and also allocate resources to retrain your staff based off your findings. You know, I mean, that's just as important. Another big important part of this is you have to monitor the bots that are put in play for potential process flow changes. You know, it's sometimes people forget you get these bots going, you're focusing on automation, but you really have to treat them just like a rep, you know, a really high performing rep. But if you're not monitoring, you know, process flow changes and contracts, you know, it can be a dangerous thing, because they're going to continue to do what they were programmed to do. Okay, so we still have time for more questions. Here's another one. Dan's probably would be a good question for you. How do you automate the findings of root causes without using manual effort?
So in terms of identifying root causes, you can use RPA technology as an example. So for instance, if you get a claim rejection for no coverage, you can verify and scrape an eligibility software system. So you could verify that, hey, I got a 27 CART code, and when I actually scrape the EMR system, the eligibility system came back saying that, you know, there was no active coverage. And when that instance comes into play, you can essentially NRP that claim, or you can go ahead and bill the patient directly if there's no other insurances. In terms of if it's a COB issue, you can use the same logic. Verifying through Medicare website is a great example. The common working file detail is very specific in terms of who is the primary payer, whether it's Medicare or whether it's a supplemental or whether there's a replacement policy built in overall. So you can use the rejection of a 22 to determine whether or not that's actually accurate or not.
All right. Dan, I think here's another good one. How do you determine the CART hierarchy?
That is a phenomenal question. So we have a lot of different ways to determine it. So we have a very low-tech way of saying we have like yellow and blue listers, which is like just determination and breakouts that we here use. So in terms of what that means, if you have for example, a 45 on a claim or a 97, in terms of building a hierarchy, some codes don't actually mean the true root problem, and sometimes they do. So if you had a 45 on a claim and every line item has a 45 applied, but one has a 197, well, the 45 to me means that that's just a contractual issue, and assuming they process it correctly, it's not really a problem. So then when you have the 197, you can say that's really my big issue on this claim. I'm seeing that it's denying for no authorization, so I would assign it that way. You can also assign based off of the largest denial issue on the account. So if you had 4 different CART codes, you could actually apply who has the largest balance within those CART codes to determine what the winning denial reason is. So, and it's depending on each payer and how those things break out.
All right. Another question we have, if you were to focus on how to get started with automation, what would be your advice for the highest priority? So that's another great question. As I mentioned previously, always have the data decide on where you should begin. You know, data-driven decisions will help you pick off that low-hanging fruit that can be automated quickly and effectively first. So the reason why that's important is because, you know, as you're spending time to tackle the tough issues, you know, hitting those easy ones will have a big return on your bottom line, and may also help convince your CFO that this is something worth investing in.
And if you're following up on accounts, I suggest denial classification.
And even, so I'd say, Dan, even expand on that a little bit. So once they break it out by denial classification, I mean, is there any main things they should be looking for within those categorizations, or just go straight off by type? So I guess my question to you will be, is there anything in the data that could be misleading, where they may think this is a leading issue, but if you dive into it further, you'll see that's not necessarily the case?
Well, I think you talked about diving down the rabbit hole a few times prior to this, and an example is you can be on a trail of what you think is going to be an automation opportunity, and as you write the rules further and further to figure out what you can actually do, you're going to find out that whittles into a very small opportunity. So determining at a first pace what's actually going to net you a good return, I think you have to go through the vetting process first before you can determine how to do that.
Okay, another question we got is, what is a recent trend you are seeing that was unexpected? So then, actually, since we still have some more time, why don't you actually walk them through some examples, but maybe you know, actually use some examples from each one of those denial reasons.
Sure. So in terms of, I mean, we just went over utilization, so I think that would be a great starting point. Looking at no auth, one big thing that's not brought up on that 197 or the 15 review is that insurance carriers are not talking very well between their authorization departments and their claim processing departments. So you can see instances of where you have done all the right steps, you have verified the authorization is accurate for the service, it's for the right date of service, for the right facility, and for the right patient, hopefully. And once that all happens, it still gets denied for no authorization. And then when you're calling, you verify that the specific auth departments are actually not processing through that information and relaying it quick enough to the claims processing teams. And that's a struggle because you've done everything right. So bringing that up in your payer calls when you're dealing with those like issues is going to be ways that you circumvent this issue and hopefully get the insurance companies to speed up the process as long as they know about it. If they don't know about it, they may not realize what's happening. So having that insight is critical in terms of utilization. I also brought up in terms of the resubmission and billing sections, a very interesting section of why claims are denying for primary EOBs. I've seen through multiple hospital systems that the actual EOBs are not attaching when doing electronic billing. And it's all because the EMR system is not being populated with the right detail, the document number, the claim number, whatever it might be in a certain box of the bill, and therefore it's not attaching when it's going through the clearinghouse and billing out. And that's just something that you can verify in terms of where you have to populate certain information. And that's something really outside the box that's not normally a focus, I think, when in terms of identifying root issues. I mean, I'd say that those are two kind of good examples of going through that.
Good. So another question we got was in a reference to the 90% that can be prevented in terms of denials. So then I think might be a good thing to dive into now is maybe give them an overview of how our root cause presentations work when we work with our clients. Not necessarily what HFRI is doing specifically, but more about that overall process. Kind of define or give them an overview of here's the type of issues we'll find, we'll discuss, who are you working with, what kind of action plans are you putting in place, and how does that all relate in order to ensure that in time they're reducing the denials.
So I think the starting point would be is that you would look at all of the data that you have available to you, and then you would see which denials are popping up as the largest issue. And from that point, you would identify which service areas have the highest affected breakout of those denials. And there's one of two ways. You can be proactive and go after the information and provide the descriptions of what's actually happening to your client or your front end, or if it's just your boss. The other option would be is that you would bring up all your findings to that individual or that group and say, where would you like a targeted approach first? Either way is a great option, and there's been positive feedback on doing it both ways. Once that information is then agreed upon in terms of where you're going to be going after, the root assessment is the part that takes a while. So you can do a lot of things electronically, and then there's a lot of things that you cannot, and you're going to have data analytic teams driving and verifying exactly what's pushing that issue. So once you actually have that information, putting this on a PowerPoint that's not 1,000,000 pages in all words is probably the most important thing to describe to high-level C-suite employee or managers.
And
so
I know you're kind of saying that in jest, but at the same time, that is a tough task because there's so much information. So you want to keep it high level. So like we said before, you don't get lost in the weeds. But at the same time, you don't want to keep it too high level where important information is being left out.
And totally agreed. And I think identifying root causes that are actual root causes is the starting point to help you see the forest from the trees. So if you can see that these root issues make up 100% of the rejections, you can then build your charts to describe exactly what's happening on those accounts. And specifically, the high-level managers want to know where their processes are broken and specifically what they can do to fix it. So not only just giving the information is one thing, but actually putting suggestions on how to actually fix it is a huge assistance, I think. Whether or not you can make that happen, usually not, but at least you can describe the possible opportunities or open up dialogue and kind of watch everyone get engaged. It's a very engaging point in terms of process improvement, and everyone is usually on board for it. It's not something to call out an individual group or a set of employees. It's how can we as a partnership get better.
Yeah, that's well said. Okay, so a couple more questions. I think we have a little more time left. One is, this one's interesting. So Dan, if you had to pick what your favorite recent trend is in terms of issue you had to tackle and relate to your clients and resolve, what would that be?
I think the most interesting one is 97 not being considered an actual denial. And so when we dive into it, 97 means inclusive. And a lot of the times it's just meaning that, hey, the services are paid at a case rate, or one service is paid including other services overall. And once you actually dive into it, some interesting findings have been that edits are turned off, and nobody has applied modifiers which would unbundle these services and ultimately get them additional reimbursement. And we've seen from multiple client reviews that there's opportunities upwards of 30 to 40% once reviewing the 97. And in terms of classifying the hierarchy, if I see a 45 and a 97 as the only codes remaining, I'm going after the 97 because there's opportunity there. In terms of the 45, it's a simple verification as to whether the claims are paid appropriately. But the 97 requires that in-depth review, which allows you to set up either an edit or something to catch additional reimbursement.
Yeah, good point. Okay, so I think we got time for one more question. This one is interesting. It kind of ties back to what you were saying before. So this person, they say they're a manager at a hospital, and they're asking, do you have any advice for hospitals who want to take this process seriously, but have struggles not only working with the IT groups, but implementing these changes?
Well, I think if you're struggling to implement the IT resources, utilize data analytics specialists. So anyone who's number focused. I think whether they're a specialist in denials or not, you can tell somebody who is just ready to break into trends. And you can have them show an impact of reviewing an issue. So you say, look, I'm going to dive into these coverage issues. Well, look, 50% of these rejections we could have prevented if we would have done this. And if you put in those steps and those measures, I think that's the starting point to saying if we put automation to this, this is just the starting point in the entire process.
Good point. All right, so looks like we're ending just a couple minutes early, but I would like to take this time to say one last time, thank you everyone for hopping on. As you can tell, these are items that Dan and I, like to talk about. And we will be having more webinars on other automation processes as well. So please look forward to that.
Thank you, everyone.
Thank you, everyone.
And on behalf of Becker's, I would like to thank John and Dan for sharing their insights and the audience for participating. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you all.